Alright, so when we're looking at CKD, this is characterized by the presence of kidney damage or an estimated GFR of less than 60 that persists for 3 months or more. So you have a progressive loss of kidney function, which often leads to needing renal replacement therapy like dialysis, hemodialysis, peritoneal dialysis, or possibly kidney transplantation. So essentially what happens is you have this increase in glomerulosclerosis that leads to a progressive loss of nephrons, and then that GFR starts declining over a period of months, 3 months, and then you'll see that progressive increase in BUN and creatinine, increase in albuminuria, and then other complications from CKD. So unlike the AKIs, which can sometimes and oftentimes result in like a complete recovery, chronic sustained injuries to the kidney leads to this ongoing, the kidneys become fibrosed and their structure is damaged. So essentially all the compartments of the kidney along with the vessels of the kidney are affected. So you're talking about your glomeruli, your renal tubules, and the interstitial space in the kidney. So I don't think we need to get too deep into this, but if it helps for you to have a background, essentially what happens is those damaged cells in the kidney are flooded with, inflammatory cells, and those cells then fill that interstitial space, and then their byproducts and collagen and proteins and stuff lead to like a scarring and a fibrosis in the kidney. So that fibrotic tissue continues to build up and it's got nowhere to go, so it compresses the kidneys, it starts damaging the tubules, and then of course they lose their ability to filter effectively. And so that's probably a bit of an outlier with CKD versus an acute kidney injury, because sometimes with the glomeruli and the tubules, those can get fixed, but that fibrosis is an irreversible process. So that's going to lead to permanent loss of kidney function. So when you have this chronic inflammation and scarring in that interstitium, that again is going to damage the tubules, impair the kidney structure. It causes damage to the epithelial cells in the tubules, and then they're not able to reabsorb like they normally would. And then on top of that, as we talk about some of the main causes for CKD, being repeated exposure to certain drugs, chemicals, whatever, or just metabolic waste products are going to damage the tubular cells, and then your CKD is going to progress. So you can refer back to your KDIGO slide from earlier, but essentially this is just showing you that CKD is a progression. There are 6 stages, and there's a stage 3A and 3B. Now, I don't know why they just didn't go 1, 2, 3, 4, 5, 6, but I wasn't there at whatever conference to make that determination. But in addition to looking at the GFR, the KDIGO also looks at the level of albumin in the urine. So A1, they look at A1, A2, A3. So A1 is considered normal or fairly close to it. Then A2 is considered, they used to call that microalbuminuria, but I guess a lot of the physicians like myself, can't pronounce that over and over again. So anyways, that's considered elevated. And then A3 is, they used to call that macroalbuminuria, which means there was a lot of albumin in the urea, as opposed to micro, which was a little bit more than normal. So, a couple little pearls of wisdom is that CKD can run asymptomatic until it's reaching stage 4 and stage 5. So the recommendation with KDIGO is that high-risk populations are screened for early detection. Okay, so we're going to look at individuals with diabetes as the main cause and hypertension. We're going to look at our elderly. And this is going to incorporate urinalysis, looking at that albumin ratio to creatinine, looking at that GFR. According to their most recent documentation that I looked at, it said that normal parathyroid levels are more suggestive of an acute kidney injury rather than a chronic kidney disease. So if our patient is having hypertension, proteinuria, elevated lipids, metabolic acidosis, that's going to accelerate the progression of CKD. So we need to, be on the up and up and treat them aggressively. If our patient has signs of metabolic acidosis, then we want to give them bicarb. So, and then all CKD patients should be checked for anemia in addition to the hypertension, acidosis, and perhaps bone disorders affiliated with that calcium imbalance. So risk factors for CKD, one is genetics. So there's certain genetic disorders that can directly impact the structure and function of the kidneys. And one of those, most commonly that you'll probably hear about, is polycystic kidney disease. Another genetic issue is some people are just genetically predisposed to kidney disorders, even if there's not like a condition per se. So it's just something that over time, perhaps with that correlation with diabetes and hypertension, that can cause damage to the kidneys over time. Lifestyle factors, so a diet high in processed foods, sugary sodas and stuff, excess sodium increase the risk of developing kidney disorders. Smoking, because it damages the blood vessels. Sedentary lifestyle, because a lack of physical activity and exercise contribute to developing hypertension and type 2 diabetes, which are the two main causes of kidney disorders. Environmental factors, actually, like air pollution, can contribute to the development of kidney disorders, as we sit here in this dirty ozone warning thing every day. Contaminated water with heavy metals, pesticides, stuff like that can damage the kidneys over time. Toxic substances like lead exposure, exposure to certain solvents, chemicals, and then, believe it or not, climate change, because changes in the temperature and changes in precipitation patterns can contribute to an increased incidence in kidney stones. Alright, so diabetic nephropathy, like I said, is the most common cause. When you have that chronic hyperglycemia, the proteins we're looking at are albumin, for one. So it starts to affect platelet activation, platelet aggregation. There's decreased uptake of glucose. You have issues with fibrinogen and clotting that leads to vascular dysfunction. You've got issues with immunoglobulins. So more likely to develop autoimmune diseases and inflammatory diseases, and also your immune system becomes suppressed. And then also you have collagen is affected. So that's where you have this development of this fibrosis that I was talking about. It can actually age your skin, and then patients develop atherosclerosis as a result. So that was probably way too much information, but essentially this stuff gets deposited into the vessel walls in that efferent arteriole, and that causes like a thickening of the efferent arteriole. And you think efferent is exit, right? So essentially this causes like an ischemic injury to the renal tubular cells, and it creates a high pressure in the glomerulus. Essentially, there is a glitch in the matrix there, and then that's where this glomerulosclerosis happens, and it's progressive, and you see that progressive decline in GFR. So diabetics that are poorly controlled, or A1C is above 7, you're going to see heavy albuminuria, and that's an indicator for, diabetic nephropathy as compared to like a hypertension related nephropathy. And fun facts, chronic kidney disease, type 2 diabetics account for 30 to 50% of patients with chronic kidney disease, and type 1 is about 4%. So if you think about your type 2 diabetics that they're not diagnosed until, older adulthood, and they've already been doing a lot of damage, you can imagine, by the time this is detected, what's already, too far gone. Then we have hypertension, which makes up about 27%. So that chronic hypertension causes thickening of the afferent arterioles. So when that lumen becomes narrowed, that causes an ischemic injury to the tubular cells, and again triggers this process where stuff is secreted that, causes glomerulosclerosis. And again, we have that decrease in GFR. And we've got our glomerulonephritis, which makes up about 14% of CKD causes. Now, I know this has already been covered, but as a refresher, glomerulonephritis is often associated with proteinuria and hematuria. And then if it's a nephritic syndrome, you might see red blood cell casts. And probably the one thing you want to focus on here is that autoimmune disorder, because glomerulonephritis can be associated with lupus, would probably be your NCLEX kind of question. Okay, lastly, we're going to talk about polycystic kidney disease briefly. And this is that genetic disorder I mentioned, and it causes these fluid-filled cysts to grow in the kidneys. And a lot of people have cysts on their kidneys, but the issue with PKD is that they grow many cysts, and that, over a lifespan, it can change the shape of the kidneys. It makes them a lot larger. And then there's a whole bunch of complications. They tend to have like really, really high off-the-chart blood pressures that, don't seem to respond well to medications, and things of that nature. And just FYI, autosomal dominant is diagnosed in adulthood. Autosomal recessive can be diagnosed in utero or shortly after a baby is born. So when you're looking at diagnostics for CKD, remember we're talking about persistent decline in GFR less than 60 mLs per minute for greater than or equal to 3 months. And you're going to determine the stage based on the GFR. So again, you can refer back to the other slide. You don't have to remember this, but like 3A is the 45 to 59, 3B 30 to 44, stage 4 is a GFR of 15 to 29, and CKD5 is a GFR of less than 15. So the other thing they look at is the amount of albumin in the urine. So the higher the number, the higher the risk, excuse me, of cardiovascular related diseases, and elevated cholesterol, because you've got the issues with the protein synthesis. And a lot of times the albumin in the urine presents itself before we actually see a decline in the GFR. So again, thinking about those high-risk patients and what kind of tests can we do to find that cause. So we're probably going to look at a hemoglobin A1C, as I mentioned, doing frequent blood pressure checks, and then looking at that urinalysis as well. So, if we see that hemoglobin A1C above 6.5 to 7, then we're thinking diabetes. If they have a persistently high blood pressure, we're thinking hypertension. And then if we're seeing that proteinuria, hematuria, and perhaps those RBC casts, those red blood cell casts, then we're thinking about glomerulonephritis. So if they've got that elevated A1C, we're thinking about diabetic nephropathy, especially if that albumin is present. When we look at the blood pressure, we never go off of one, so we're looking for those multiple recordings. And one thing we want to think about too is the patient compliant with their antihypertensives? So have they been taking their medications or not? For the glomerulonephritis patients, they might need a more extensive workup. We might be sending off that renal biopsy and additional lab work. And they might have that renal ultrasound to see if there are cysts on the kidneys. So if we're currently seeing a GFR less than 60, then we hopefully can gain access to previous blood work, previous urine tests, that will help us quickly determine, is this an AKI or is this CKD that was undiagnosed before? So again, we're looking at our patient's history. Do they have chronic hypertension? Are they passing protein in their urine before? Do they have chronic prostate issues? Physical assessment wise, are there issues with their skin pigment? Are we seeing, do they have those little scratch marks on their skin? That could be a sign of uremia. Looking at, what does their EKG look like? Do they have any signs of heart failure? Does their EKG show left ventricular hypertrophy, which, is indicative of heart failure and potentially a chronic issue? Another thing you want to look at too, that I don't think we're going to talk about too much, but things like cancer, like multiple myeloma, or if somebody's having a vasculitis, those can be diagnostic as well, but those are not going to be our main focus. That's, I would say that's more of a specialized issue that we don't need to worry about. And again, we said a normal parathyroid hormone level is more suggestive of an acute kidney injury rather than chronic kidney disease. So sometimes to distinguish between an AKI and chronic kidney disease, typically what you're going to see is urine, like a 24-hour urine to measure creatinine clearance. There is another test, like the inulin clearance test, but it's not widely used. It's not widely available. It's I think in order to get the most accurate result, like you're supposed to be catheterized, so then you're running the risk of introducing a CAUTI. So typically what you're going to see is like a creatinine clearance study. So again, if we're doing that 24-hour urine testing, we need to make sure that it's kept on ice and those big brown bottles, etc. Another gold standard test is the kidney biopsy. And I don't think I mentioned this on the last slide, but that helps us determine the extent of, how much fibrosis is occurring in the kidney. So late stages of kidney disease, chronic kidney disease rather, we're going to look at metabolic acidosis again, hypervolemia, hyperkalemia, uremia, a secondary hypertension, hyperparathyroidism, anemia of chronic kidney disease, and hyperlipidemia. So we now know how those things happen, and let's look at how we can manage those. So first we're looking at metabolic acidosis, and of course we want to prevent that from worsening. So we're going to give sodium bicarbonate to the patient, and then you want to monitor their bicarb levels, either looking at a renal function panel, ABGs or venous blood gases, to make sure that they're hopefully getting to a normal pH. So for an NCLEX type question, think about what does that look like when your patient is in that acidotic state. So are they having that shallow, rapid breathing because they are trying to compensate and blow off more CO2 to bring up their pH? Alright, next let's talk about hyperkalemia. So how are we going to manage that? Well, if the person is overloaded with volume, they're hypervolemic, and they have hyperkalemia, we can give them loop diuretics. If they're not overloaded with volume, we can give them like a potassium binding resin. And there's a couple of newer-ish ones on the market, but the one that you'll probably see or hear about the most is called SPS, or sodium polystyrene sulfonate. That can be given orally or via a lovely rectal enema. And essentially how it works is it binds to the potassium ions in the gut and prevents intestinal absorption. Now the problem with that is it creates a lot of GI disturbances, so diarrhea, people can get nauseous, vomit. You could send the patient the other way, and then in turn they become hypokalemic, so you got to watch out for that. And the opposite of metabolic acidosis, which would be that alkalosis. And it can cause bowel necrosis as well, so that would be an adverse reaction for that drug. And when you're messing with potassium levels, you always want to monitor for EKG changes. So with hyperkalemia, you're going to see peak T waves and widened QRS complex. Typically, sometimes you'll see flattened P waves, and you might see heart block. So, you just want to watch out for changes, which, you could lead to VFib and perhaps asystole, which would make for a rough shift. So, keep an eye on your patients. So hypervolemia, how's that person going to present? So think about your fluid overload patients. They could be hypertensive, they have edema, could have pulmonary edema, pleural effusions. They could have like hypervolemic hyponatremia, so you'd see signs of hyponatremia. Depending on, what their status is, then typically if they're hypervolemic, then you want them to have a low sodium diet, and you can also give them loop diuretics. Of course, you want to monitor daily weights, and how do we know our treatment was effective? We want to see their weight go down, we want to see their edema go down. And we talked about the nastiness of uremia, and one of the issues being a platelet dysfunction. So if your patient presents with this bleeding, what are they going to look like? Well, they might have a nosebleed, they might have a GI bleed. One thing that could be given, and this is generally like if the patient is going to be going down for a procedure and they're at risk for bleeding, is they could be given desmopressin or DDAVP, and essentially what that is like a synthetic antidiuretic hormone. And you'll hear about that again when we get to our endocrine lecture with our patients with diabetes insipidus. But as far as I'm concerned, I worked on a renal floor, and in 26 years, I've not had to give that. That's more of an ICU thing. So I'm putting it out there for you, but I am not worried about that at this level right now. But essentially, how it works as far as the bleeding goes is it increases the blood levels of certain clotting factors, and that results in less bleeding for those patients who have low levels of those factors. Remember we talked about when our patient is peeing out all these extra proteins, and some of those clotting factor proteins is what we're circling back to right now. And just on that note with the with the protein issues, I mentioned before that the patients can be immunocompromised, and so they're at increased risk for infection. So one of the big things that you'll see on an NCLEX test is that, we're not going to just like randomly give them antibiotics, but we want to be preventative and encourage them to get their pneumonia vaccine and, their flu vaccine as well. I want to backtrack a little bit to the hypertension management because it's late and I can't remember if I said this already or not. But we may give our patients ACE inhibitor or ARBs with CKD, and the reason is obviously to manage their blood pressure, but also it helps decrease the filtration of albumin, and so they'll have decreased spilling of albumin in the urine. So we give it to control not only the hypertension, but to minimize the proteinuria. And, one of the new things now are the SGLT2 inhibitors that a lot of people are taking for weight loss, like the semaglutide and the tirzepatide. They are finding great results with those, with helping to, minimize some of the cardiovascular effects in patients with chronic kidney disease. So, obviously, how do we know it works? Their blood pressure is controlled, but we do need to monitor creatinine levels if we're giving them, and also, remember, if you think about that whole mechanism with aldosterone, right? The opposite happens, and it can cause a hyperkalemia. Now, with that being said, sometimes the benefit of decreasing the amount of protein in the urine outweighs the hyperkalemia, and they may, manage the hyperkalemia with like the SPS that I just mentioned. Okay, we're getting there. So, CKD, our patients will have an elevated phosphate level. If they have an elevated phosphate level and a decreased calcium, you'll put them on a low phosphate diet. and you can put them on phosphate binders as well. So phosphate binders work kind of like a sponge, and they soak up all the phosphate so that it doesn't get into the bloodstream, and what happens is the patient will eliminate it in the stool instead. So it's important with phosphate binders. It should be taken like 5 or 10 minutes before a meal, or like up to like right after the patient has eaten, in order to get that benefit. So what are our phosphate binders? Well, calcium carbonate, or Tums, is actually a phosphate binder, and it's cheap, right? But the issue with that is that it has a high calcium load, and that contributes to like calcification of the vasculature. There's another one called Foslo that's also calcium based. It's calcium acetate, and it works in kind of the same way. Probably what I see most commonly now is Sevelamer, aka Renagel. So that's free of calcium, but the problem is it's very expensive for one thing, and the pills are huge. And then also in CKD, they might give vitamin D. If the calcium's low and the vitamin D is low, the vitamin D is going to help with calcium absorption, and that'll decrease that the PTH levels that tend to be elevated in CKD. If the calcium level is high, they can administer a calcium mimetic, and that's called Cinacalcet, and that mimics the calcium at the parathyroid hormone receptor site. And basically because of that, the parathyroid hormone secretion will be reduced, and then that will result in a lower calcium level being seen. Again, I think that's another one of these things that's like very specific, and I'm not particularly worried about it, but if you had that what if burning question in your mind, there is your answer. And then in some extreme cases, they may have to do like a parathyroidectomy if that calcium level is getting out of control. So there is this complication related to CKD that's fairly rare, but maybe not if you work on a renal floor. And if you have too much calcium and too much phosphate, that can actually cause deposits into the vessel walls, and then it starts to calcify, and it's called calciphylaxis. Go figure. It can actually like cause narrowing of the vessels, like towards the skin layers, the dermis and the subcutaneous layers, and then the skin actually becomes ischemic, and essentially it becomes necrotic. So it can happen like over the chest area and also on the extremities. All right, we mentioned our CKD patients are chronically anemic, like as defined by a persistent hemoglobin less than 10. So what we will do is, they'll look at some iron binding levels, like ferritin levels. If the patient needs iron supplementation, we can give them iron supplementation. And they do that, and then they'll also give them erythropoietin to stimulate red blood cell formation. Remember, a wet bed, one of the roles of the kidney is to secrete erythropoietin, but obviously if they're not working, then that's not going to happen. So, how do we know it's working? Are they maintaining that hemoglobin above 10? If they are chronically anemic, Some patients do need a red blood cell transfusion, and if they're scheduled for dialysis, a lot of times while they're being dialyzed, they can make that happen. And since we're on the subject of management, just like with the AKI stuff, avoid things that are nephrotoxic, renal dose your medications, avoiding contrast, and all that good stuff. Now, if we tried all of these 8,000 things that we just discussed, and that's not working, then we get to the point of the patient needing dialysis. Alright, so we talked about dialysis on the AKA recording, but regular hemodialysis, patient's going to need vascular access to be connected to the dialysis machine, typically 3 times a week. With an acute kidney injury, they'll have like a tunneled catheter placed in interventional radiology. But right now we're talking about chronic kidney disease. So they're going to need something more long-term. Now, if they need dialysis right now and they don't have a long-term thing, then yes, they're going to have a central venous catheter, tunneled catheter placed to bridge them to the point where either their AV fistula or their AV graft is usable. So AV fistula is the preferred long-term dialysis access because it's more patent and there's less risk of infection. So the downside of an AV fistula is that it takes longer to mature before you can actually use it for dialysis. So it can be maybe as little as a month. It can take sometimes several months with people before they're able to use it. An AV graft is another option. It's easier to establish, however, the line, it's less patent than an AV fistula, so it can potentially clot off and not work anymore. So, quick and dirty refresher, the blood is taken out from the access site, it goes through the machine, it has the dialyzer with that dialysate that is going to filter the waste and the extra fluid, and then it's returned back to them through that vascular access. And one thing I did not mention on the last slide is that during dialysis, they might give blood thinners like a heparin to prevent clotting during the process of hemodialysis. Now, the next option is peritoneal dialysis. So with this one, there is a catheter that's placed into the peritoneum, and then the dialysate, we infuse it into the peritoneal cavity, and the patient's peritoneum then is used as a membrane, like a filter, in other words, that when the dialysate's in there, it pulls off the waste products from the bloodstream into the peritoneum. So we instill it into the peritoneum, we let it, dwell in there for a period of time, and then we drain off the dialysate through the catheter. And this happens, a lot of patients go through this process where they do this every night, so that, at night, they might have a machine at home where it infuses and then drains. In the hospital, I've had to do it every so many hours, and then you leave it in for 2 hours and then you drain it. So it just depends on what your patient's blood levels are and how stable they are. Peritoneal dialysis is used a lot less frequently in the United States compared to other countries. I'm not exactly sure why, but you can imagine that a complication of peritoneal dialysis would be peritonitis. So when you see peritonitis, it's a lot of abdominal pain. The abdomen is rigid and very tender. So keep an eye out for that. That's your big complication with peritoneal dialysis. So hemodialysis, they're drawing off that fluid. We're worried about hypotension. Peritoneal dialysis, worried about hypotension, but your NCLEX thing for peritoneal is going to be peritonitis. Go figure. Now, sometimes with peritonitis, they actually need to infuse antibiotics into the peritoneum to treat that. And I actually want to go back to the hemodialysis for a second. I mentioned to monitor for hypotension. The other issue is if you're looking at a central line access, like for those, short-term, the temporary tunneled catheters, that is your CLABSI. And CLABSI stands for Central Line Associated Bloodstream Infection. And we're going to be covering that in an upcoming lab, so I won't get too much into it right now. But, you've got a central line infection, which can lead to sepsis. So you'll learn about ways to keep the site clean, keep the dressing clean, and so on and so forth when we get to that point. Alright, I think we're good with the medical management that I covered on a few slides back. Let's talk about collaborative care. So this is, as you can probably tell, is a, there's going to be a lot of interprofessional collaboration with patients like this to make sure that, patients are sticking to the current guidelines and best practices, and that the staff is as well, that we're addressing complications, that we're talking about lifestyle modifications, and things like that. And one thing I wanted to mention is that there is also the possibility that you can have an acute on chronic kidney disease, right? So they already have chronic kidney disease, but now they have another acute kidney injury. So let's say they had chronic kidney disease and then their tunneled catheter got infected and they developed a CLABSI, and now they're septic, and now they have a pre-renal acute kidney injury. So we're looking at, nephrology, we're looking at interventional radiology for that line placement, primary care docs, right, because they, and those nurse practitioners, they're the front line that, keeps that patient from being admitted into the hospital. So what about nutritionists? So patients with advanced CKD are at risk of malnutrition. If they're chronically acidotic, they might need to take bicarb supplements. We have, pharmacy involved in this. If we are renal dosing medications, if we're talking about that diabetic, we want to make sure that they have tight control of their blood glucose to delay that onset of albumin in the urine. And overall protein restriction will slow that CKD progression. Now another thing that is coming up on an upcoming slide is the option for kidney transplant. So we're going to have that surgical team on board. And this is a treatment of choice for end-stage renal because long-term those patients have better outcomes. Now, we might have a patient that, is end-stage renal, they're sick and tired of all this stuff, and they don't want to have dialysis anymore. In that situation, we can look at palliative care and consult the palliative care team. NCLEX low, so look at those dietary restrictions. So think about those common foods that have a lot of sodium, have a lot of phosphorus, etc., etc., and adjust the intake of those based on, your patient's current status and their lab values. For patient education, everything that we've already been talking about. The biggie is about 85% of CKD patients have hypertension, so they should be taught to measure their blood pressures daily, keep a log of their blood pressure, keep a log of their daily weights, and they should have parameters for when to report any abnormals to their healthcare provider. Also, patients that are pregnant or planning to become pregnant, pregnancy can exacerbate CKD. And then also some medications that we commonly use in CKD, the big one is like ACE inhibitors that you'll see on NCLEX. Those are teratogenic, so you wouldn't want to take those when pregnant. Oh, in case you didn't notice, there's a lot to balance with fluid and electrolytes here. So I probably could have just mentioned this on another slide now that I'm looking at it, but sodium restriction, so you'll commonly see patients on a 2-gram sodium diet. So that could be a teaching point too for patients, how to read their food labels to identify, what kind of foods are high in sodium and how to count their sodium content. We mentioned tight glucose control. One thing with CKD, and they're not really 100% sure why this happens, but patients with CKD are more resistant to insulin. So the patients may find themselves needing a higher dose of insulin, and they, postulate that that's because of all the inflammatory markers being secreted. And also, I should clarify what I mentioned before about the low protein diet. So the low protein diet, if they have chronic kidney disease but they're not on dialysis, you want to limit their protein, because the more protein that has to be removed, the harder the kidneys need to work to get rid of it. But once they're on dialysis, they should have a higher amount of protein to help maintain protein levels. And since the dialysis removes the protein waste products from the blood anyway, the low protein diet really isn't needed. Okay, so when the kidneys fail, we said our options are dialysis or transplant. So when you get a kidney transplant, the good kidney is placed inside the body, to do the work that your kidneys were no longer doing. So average length of a kidney that lasts from a living donor is about 15 to 20 years, and it's less from a deceased donor. And obviously there's potential complications with that. There's a increased risk for infection in post-transplant patients. They have to take anti-rejection drugs, which, suppress their immune system. So they need specific prophylaxis, when they're going for certain procedures. They should be vaccinated. And actually, because of the immunosuppression, patients with kidney transplants have an increased risk for malignancy, and commonly skin cancer. Okay, so what's the benefit? Well, if the kidney takes and it really starts working, then they no longer have to go to dialysis, which is a big plus, because that puts a damper on a lot of life plans, right? However, one thing it's important to teach your patients that, once they have that kidney, they may still need dialysis. So it's not necessarily a cure-all. And some may need it for a short amount of time, and then that kidney starts picking up and working. And then sometimes that doesn't happen. So they've got to take the anti-rejection drugs. I know with COVID, like recently I had a student at the hospital, and the patient had just finally received their kidney, and they got COVID, and then, COVID knocked them for a loop, and their kidney rejected. So, there's a lot of ups and downs when you're talking about transplantation. And those patients know that they really need to take those anti-rejection drugs every day. Sometimes when they are hospitalized, they're very anxious, if you're running late with their medications. So keep that in mind, when these patients are on their call light saying, where's my Prograf or where's my CellCept? So when they do the surgery, it takes about 4 hours, and they put the donated kidney into the lower belly area, and it connects to the blood vessels and the bladder. And fun fact, they do not take out your own kidney when you get a transplant. Unless there's some medical necessity to remove it, they leave it in there. So if you're caring for someone that's had a transplant, pain management is, post-operatively is going to be an issue. They tend to go home within a few days if they don't have any complications. They're probably going to have a lot of doctor's appointments, follow-up appointments, checking lab work and things like that. And finally, that is all she wrote.